spine, lateral view, you could see nicely mid-thoracic spine, narrowing of the another TB spine, lateral view, you could see nicely mid-thoracic spine, narrowing of the joint space, minimal narrowing, and there is not much of soft tissue swelling, either prevertebral or a paravertebral in the conventional films. Then, if you take a CT of the spine, look at the small soft tissue swelling or abscess on the right side, with the destruction, of course, of the vertebral body. Spondylitis again, 57-year-old male with history of severe backache and weakness, both lower limbs. And here you can see in the coronal plane and in the lateral views, psoas abscess with multiple vertebral body involvement, multicentric type of tuberculosis, and you could see the psoas abscess clearly. Sometimes, if the patient cannot afford, you take a plain films of the spine, you diagnose tuberculosis of the spine, and you don't know how much of the abscess is there. In those cases, if you do an ultrasonography, it will tell you the size and shape of the abscess, and immediately you can put a drainage tube also, because after all, such a big abscess, it has to be drained. Chemotherapy alone may not resolve the abscess. Now, tuberculosis arthritis of the shoulder. This is a 30-year-old male, pain right shoulder, and of course, plain radiograph shows just osteoporosis, nothing else. And then you take M.R.I, T2 weighted image, and star images. There is joint effusion. On plain films, you cannot tell joint effusion with altered signal intensity involving humeral head and also incidentally noted axillary lymphadenopathy. Look at the advantage of M.R.I as opposed to plain film. Even CT may not show the axillary lymphadenopathy. Tuberculous bursitis. In bursitis, you may not see any lesion in the adjacent bone. All you see is just a para-articular osteoporosis. This is a 30-year-old male with history of swelling of left shoulder. There are so many causes for left shoulder swelling. Then soft tissue swelling around left shoulder joint. And if you do an ultrasound, you see it reveals multiple well-defined soft tissue lesions. These are hyperechoic. It's not just abscess, it's not just synovitis, but hyperechoic lesions. And lo and behold, if you take M.R.I, it nicely shows subacromial and subdeltoid bursitis because of the synovial thickening with so-called melon seed bodies, which the pathologist described, and today we are seeing an M.R.I these melon seed bodies. Those are the echoic lesions that you found in ultrasonography. Often we come across in a child with swollen knee. What type of arthritis is it? Is it juvenile rheumatoid arthritis, pyogenic arthritis? And if you take a plain film, there is nothing in the bones except osteoporosis and a huge soft tissue swelling in the suprapatellar bursa. That's how tuberculous synovitis expresses. Then you may do ultrasound and other investigations. TB of sternum. Sternum also is not exempt from tuberculosis. Here you see. And PA and lateral views of the sternum may not help that much unless grossly the sternum is eroded. But on the other hand, on CT you can see the abscess and the low attenuation LU in the center, indicating that it must be tuberculous abscess. And again, a cross-section view, another case of 30-year-old male, again with severe backache for 2 months, and bilateral tuberculous psoas abscesses. Multicentric tuberculosis, already we have referred to earlier in the spine. Here in a PA view of the chest, hilar and axillary lymph nodal calcification is there, indicating that it is an old tuberculosis with splenic calcifications. That red arrow on your left side shows splenic calcification. These are all tuberculomata that are calcified. And in the one on your right side is a different case. That's how tuberculous abscesses, or if you want to call it tuberculous infiltrates in the spleen, show as lucent areas in the spleen. Ultrasonography also reveals similar lesions. There is one form of TB, cystic TB, although it is common in children, but occasionally you can get in adults also. Multiple lytic sometimes oval lytic areas in the bones. Particularly look at the right middle ribs, irregular lucencies with little periosteal reaction. Osteomyelitis, like any other osteomyelitis, you can get in TB also, but except in pyogenic osteomyelitis or fungal osteomyelitis, as I said earlier, there is intensive bone reaction. And pyogenic osteomyelitis can be divided into 3 stages: acute, subacute, and chronic, with a huge sequestrum. Whereas here in tuberculosis, the sequestra are minute debris, necrotic debris, and lot of osteoporosis is there, minimal sclerosis. This is tuberculosis of the calcaneum. Again, tuberculous dactylitis, you could see in children particularly, spindle-shaped, lytic areas in the arrows point out. And lastly, I said tuberculosis from head to toe, so I have to do a toe radiograph. Look at the proximal phalanx of the great toe. Osteoporosis of the bones is noted, lytic areas, that lytic area is going into the articular margin producing arthritis, and soft tissue swelling is proved to be tuberculosis. Why can't it be fungal? There should be intense bone reaction and sclerosis because of the chronic inflammatory change and infective stage. Now we come to the gastrointestinal tract. At one time, before the pasteurization of milk, gastrointestinal TB used to be very common. But today, you see it, but it's not because of the milk or unpasteurized drinking of milk. Tuberculous swallowing of the sputum may produce this. Tuberculous peritonitis, there's an expression. Often, glibly, the clinicians call investigate tuberculosis of the abdomen. There is nothing like tuberculosis of the abdomen. Tuberculosis of the abdominal contents, either peritonitis, mesenteritis, lymphadenitis, or the bowel involvement. Peritonitis, wet type, large amount of free or loculated fluid, occasionally it may be loculated. Dry plastic type, it may plaster the entire omentum like a cake. Cases adenopathy and adhesions. Fibrous type, irregular mass of soft tissue density in the omentum and mesentery, matted bowel loops, and loculated ascites. Let us start with the esophagus. It is rare, but still you see tuberculosis of the esophagus, either from the lymph nodes of the mediastinum eroding or involving the esophagus, or primarily the esophagus because the swallowed sputum, stasis, ulceration, and granuloma formation. This is note the sinus tracts, that is classical, multiple sinus tracts, and irregularity of the mucosa. Irregularity of the mucosa you can get in caustic ingestion or any other inflammatory changes, but those small sinus tracts is characteristic of tuberculosis of the esophagus. Now gastric tuberculosis is also known, but is not that common, whereas duodenal tuberculosis, because the lymph nodes near the duodenal loop are over the pancreatic head producing non-specific changes in the duodenum. This is duodenal tuberculosis. Small bowel, very common, tuberculosis of the small bowel, and then often produce obstructive symptoms. Rarely it is ulceration, rarely it may produce a mass clinically. But then sometimes, because of chronic obstruction, enteroliths are formed. Whenever you see multiple laminated enteroliths, think of tuberculosis. Any other chronic obstruction also may produce, but commonly tuberculosis, and because the adhesions are the strictures. Bowel involvement, common terminal ileum is the most frequent site of involvement. Narrowed, thickened, and rigid terminal ileum with some proximal dilatation. Some means, depending upon the stricture or narrowing, may be marked dilatation, which may produce acute obstruction, or it may be slow dilatation and thickening. Small, distensible, thick, pulled up cecum. Non-distensible cecum, contracted, with a disturbed ileocecal angle. Ileocecal tuberculosis is the most common. That's how it expresses. But then in our country, amoebiasis is also common. But amoebiasis rarely involves the distal ileum. Involves the cecum and ascending colon, maybe the rest of the colon, but rarely involves the distal loop of ileum. That's how you differentiate tuberculosis from amoebiasis. Crohn's disease, difficult because it involves the ileum as well as the cecum. And here, for example, note the narrowing, beaded appearance of the small bowel with mild proximal dilatation. A sinus tract, cecum, contracted, and a sinus tract is noted. Maybe there is a cutaneous fistula also in this particular case, tuberculosis of the cecum. How about other granulomatous lesions of the cecum? I said already amoebiasis, occasionally actinomycosis, occasionally Crohn's disease, occasionally some other infections, strongyloiditis, for example, can involve the cecum in immunosuppressed patients particularly. Another example, or few examples of ileocecal tuberculosis, contracted cecum is pulled up. That is characteristic. And the distal ileum is narrowed. Sometimes you can see acute ulcerations. And then partial small bowel obstruction. Marked contraction, pulled up cecum, and multiple strictures of ileum with proximal dilated loops. As I said earlier, it is very, very difficult to differentiate this from Crohn's disease. Of course, statistically, 90% of the cases are tuberculosis and 10% maybe, or even less than 10% may be Crohn's disease. Crohn's disease also we see in India, it's not that uncommon. This is a specimen, resected specimen, in the days when it is contracted cecum and distal small bowel obstruction, you have to do some surgery. So this is a ileocecal tuberculosis, so a resected specimen. Hemicolectomy they do, including the ileectomy. This is a 35-year-old female, complains of pain abdomen for 6 months. Several examinations were done, including colonoscopy. They couldn't pass the colonoscopy beyond the ascending colon, and they didn't take a biopsy. And on a barium enema, you could see there is a partly evacuated and double contrast barium enema. The IC junction is high, contracted cecum, and then above the cecum, the ascending colon is annually constricted. This annular constriction often simulates the apple core deformity of carcinoma. So you have to be careful. This proved to be contracted cecum and ascending colon due to tuberculosis. In HIV, tuberculosis of the GI tract, how does it express? Either primary or secondary to the reactivation of disease. In most cases of disseminated infection, it is new primary rather than reactivation. Observe this. That's why in adults also you may get lymphadenopathy, hilar lymphadenopathy, paratical lymphadenopathy in the chest film. Mycobacterial tuberculosis or MTB infection seen with higher CD4 count of 200 cells per microliter. Mycobacterium avium is also common in intracellular, seen with CD4 count of 100 cells per microliter. That's how clinically or laboratory-wise you differentiate. Pancreatic tuberculosis, quite rare, but still you may see pancreatic mass with necrosis. FNAC proved to be tuberculosis because we had to do FNAC because we had to prove the histological nature of it, and this proved to be tuberculosis. Radiologically, you can't make a diagnosis even if there is calcification. Again, pancreatic and ileocecal tuberculosis. As I said earlier, again repeat, it is a systemic disorder. In this particular case, not only the ileocecal region, but also the pancreas is involved. Same case, pancreatic and ileocecal tuberculosis, histological picture. And this particular case, I remember, 52-year-old woman comes with high degree of temperature. And then this temperature has been running for 2 months, evening rise of temperature. So naturally, they ascribe it to some sort of infection. All investigations from head to toe were done. And then for some reason or other, ultrasound showed some node, para-aortic nodal lymphadenopathy, something vague, question mark they put. CT definitely shows that there is an abscess, and it is a tuberculous abscess. Now we come to the urinary tract. Occasionally they say the primary tuberculosis can involve the kidney, primarily, not in the lungs. But that of course we can't diagnose. And urinary tract, males kidneys, ureters, bladder, prostate, urethra, seminal vesicles, vas, epididymis, and testis. All these can be involved at one time or other. And classically, in old days, on a plain film, you could see a classical putty kidney, the homogeneous calcification, either contracted or enlarged on the right side. It is a pyonephrosis. All the dilated calyces, the margins are calcified, almost simulating a hydatid cyst. This is IVP. Not only the putty kidney on the left side, but the right kidney also is contracted, right ureter is dilated, and a thimble type of bladder. The entire GI tract is involved. One on your right side, again, calcification in the left kidney and the right kidney is not well visualized. The bladder also irregularly contracted. We don't know whether it is real tuberculosis or just a non-specific cystitis. Again, another bilateral calcifications in tuberculosis. In IVP, non-functioning right kidney, left kidney functions, but the ureter is straight. Another example of a putty kidney, thimble bladder, and irregular calcifications on the right kidney with strictures of the ureter. Let us talk of something about the theory of tuberculosis of the urogenital tract. Renal tuberculosis, imaging, intravenous urography, so far it has been the first screening method. Moth-eaten calyx or smudged papilla, and then feathery appearance of the surface of the papilla due to erosion. Earliest sign of renal involvement. Cavities communicating with the collecting system, stricture of the infundibulum producing calyectasis, or renal pelvis producing hydrocalysis. Tubercular pyonephrosis, the dystrophic calcification I showed you earlier, calcified hydatid, putty kidney. Ureteral tuberculosis, location commonly distal third, more involved. Imaging, sawtooth ureter, multiple mucosal ulcerations, and wall edema. Beaded type of ureter, alternating areas of strictures and dilatations. Corkscrew ureter, marked tortuosity with strictures and dilatations, pipe stem type of ureter, straight. It doesn't show any peristalsis. Thick and straight ureter, vesico-ureteral reflux, because the uretrovesical junction is ulcerated and becomes patulous. Again, some more examples of urinary tract tuberculosis. Non-functioning right kidney with multiple left ureteric strictures with thimble type of bladder. Right side note on CT, there is a hydronephrosis, rather we should call pyonephrosis. Some more examples. One on your left side, you have seen already thimble type of bladder. Then the colonization of the ureter is another example to show that it must be tuberculosis. It doesn't distend properly. And then on your right side, IVP, but you see the left sacroiliac joint is involved with a soft tissue mass producing extensive pressure over the ureter. This is tuberculosis of the left sacroiliac joint with a huge abscess. Now, bladder tuberculosis. Already we have mentioned a chronic thimble contracted bladder is indicative of tuberculosis, but acute or subacute ulcerations and filling defects may be seen because of the multiple granulomatous lesions. Male genital tuberculosis affects prostatic tuberculosis, epididymitis, and testis. But these are non-specific. You cannot say it is definitely tuberculosis unless you correlate with other findings involving other organs with tuberculosis. Again, to show a contracted bladder, the prostate impression is there, but it may be just normal enlargement of the prostate and reflux into the ureters, which are mildly dilated. And then, again, about 4 or 5 decades ago, we used to see calcified mesenteric nodes due to tuberculosis. Nowadays, we don't see much. Rarely we see that. One on your right side, calcification of the adrenals is common in tuberculosis, producing so-called Addison's disease. Contracted, calcified. Seminal vesicles, rare, but still on a CT, you could see multiple calcifications in the seminal vesicle area. Again, M.R.I. showing the same thing. And a plain film of the pelvis, including the pubic symphysis, you could see nicely calcified seminal vesicles, contracted, tubular. Not only that, vas deferens, also calcified. This is typical of tuberculosis, but occasionally in diabetic patients you may see the calcification of the seminal vesicles and vas deferens also. So one has to be very careful. Epididymo arthritis with abscess, ultrasound, thick-walled mixed echoic lesion in the left testis showing peripheral increased vascularity. Proved to be tubercular epididymo arthritis with abscess. Female genital tract, any of the organs, vagina, cervix, uterus, fallopian tubes, ovaries and parametrium. Female genital tract tuberculosis can result in salpingitis and tubo-ovarian mass, usually abscess or pelvic inflammatory disease, they call it. One on your left side, tuberculosis with adhesions and dilatation. One on your right side is hydrosalpinx, one of the manifestations due to tuberculosis. Again, a few examples of tuberculosis involving the tubes. Isthmic nodosa, beaded appearance, supposed to be classical of tuberculosis of the salpinx. Tubo-ovarian abscess, part of it is calcified, that means it's chronic. Somehow, in tuberculosis, calcification is common, as opposed to pyogenic or fungal abscesses. Again, tuberculosis of the hydrosalpinx, bilaterally fixed tubes also is another characteristic of tuberculosis. As we said earlier, musculoskeletal tuberculosis is common and expresses either in arthritis involving the joints or osteomyelitis or spondylitis. Axial skeleton is involved about 70 to 75% of the time. Arthritis is of course the most common. Osseous tuberculosis say 10 to 25%. The rest of the 80% will be the arthritis or joint form. Location, hip and knee, peripheral joints. Often it is monoarticular, while say rheumatoid arthritis, either juvenile or adult, it is bilateral, whereas here it is only one joint is involved. Femoral striate imaging, gradual narrowing of joint space or thinning of the cartilage as compared with pyogenic type of joint due to slow cartilage destruction, marginal peripheral erosions, and then juxta-articular osteoporosis. In a plain film, juxta-articular osteoporosis, relative sparing of the cartilaginous space, and then the third one is peripheral erosions. Early radiograph, joint effusion may be seen, and para-articular or peri-articular osteoporosis. Late radiographs, marginal bone erosions, joint space narrowing, it can narrow completely. Increased soft tissue around the joint, kissing sequestra. In the spine, wedge-shaped areas of necrosis on both sides of joint due to infection of the subchondral bone. And eventually it may result in fibrous ankylosis. As opposed to pyogenic type of arthritis, it may result in bony ankylosis. So there are some atypical features in skeletal TB. One, multifocal, is not common. That's why you have to do, for example, axial skeleton is involved, you have to do a M.R.I. scan. Unusual distribution, rare sites, unusual distribution, for example, if you take tuberculosis of the spine, common is intravertebral space involvement. Uncommon is anterior erosion. Most uncommon is compression of the vertebrae. Atypical reaction in the sense we said earlier, periosteal reaction is much less, reactive sclerosis is much less. But in a patient who is partially treated or whose resistance is high or the dose of the infection is micro, in those cases intensive bone reaction may be seen, but it is exceptional. Large abscesses, For example, tuberculosis of the thoracic spine, I have seen abscess coming down all the way presenting in the thigh. Lack of involvement of disc in spinal TB, of course. Without disc also you can see tuberculosis. Osteomyelitis, children less than 5 years. Adults also you can get, but more common in children. Metaphysis with transphyseal spread. See, we always say physis or growth plate acts as a resistance. But from the periphery, the infection go and involve the epiphysis also. Poorly defined lytic lesion with minimal or no surrounding sclerosis, as we said, sclerosis is less, varying degrees of periostitis if it occurs in the long bones, much less than pyogenic osteomyelitis. Cystic tuberculosis, well marginated, round or oval lytic lesions with variable amount of sclerosis, again, commonly is in children involving the peripheral skeleton. You have seen earlier the bones of the hands. Spina Ventosa, there is a special form of Tuberculous Dactylitis, ballooning dactylitis with erosion of endosteal surface. Tuberculosis of the hip, various forms, for example, calcification in the gluteal region with erosion of the greater trochanter. Whenever you see a film like this, it must be tuberculosis, nothing else. Because bony protuberances like acromion, greater tuberosity, greater trochanter, ischial tuberosity, iliac crest, these are some of the bony protuberances which are commonly involved by tuberculosis. One on your right side, tuberculosis of the hip joint, but then you see variable amount of sclerosis. You won't think it is tuberculosis, but slow growing tubercular bacilli and slow infection, prolonged period, it may induce osteosclerosis. We said earlier, bilaterality is rare, but you see the hips bilateral involvement of tuberculosis. The one down, you have seen the sacroiliac joint already with the abscess formation. Multicentric TB. This patient actually on a plain film, they diagnosed as lymphoma. And then we took M.R.I, multiple lytic areas, and look into the coronal section, there are abscesses. So it must be a tuberculosis infection. M.R.I, how does it help? Multiple lesions, as we said earlier, marrow extension from one bone to the other, high sensitivity like isotope bone scan. Soft tissue involvement is better seen, and spinal canal contents also, which may be involved, for example, dura, subdural, or the spinal cord may be involved by extensive pressure or extension to the cord. Tuberculosis of the elbow, periarticular osteoporosis is most pronounced with the destruction of the articular ends and soft tissue swelling. Patella may be involved. Look at the erosion of the inferior portion of the patella with soft tissue. No bone reaction, typical of tuberculosis. Of course, on ultrasound you can outline the abscess. Ankle, look at the pretuberculous bursa with an abscess formation. Tuberculosis dactylitis, spina ventosa, I was referring to earlier, as if there is a wind blowing the phalanx, widened central lucency, with a huge soft tissue swelling. So conclusion, as I emphasized earlier, tuberculosis is a systemic disorder affecting the whole body with focal expressions from head to toe, anywhere, any organ, bones, spleen, the liver, GI tract, GU tract, in the female's genital tract, all these can be involved, apart from what we know commonly as pulmonary tuberculosis.